So now I am going to speak on this topic hypogonadotropic hypogonadism in girls. So complete contrast topic, that is precocious, this is delayed puberty. And in fact precocious puberty is 10 times more common in girls and delayed puberty is 10 times more common in boys. Not that common in girls, this entity, okay. So some overlapping slides are there. Normal puberty in girls starts with telarchy, then pubarchy, followed by menarche. Thank you, madam. So good afternoon, everyone. So now I am going to speak on this topic hypogonadotropic hypogonadism in girls. So complete contrast topic, that is precocious, this is delayed puberty. And in fact precocious puberty is 10 times more common in girls and delayed puberty is 10 times more common in boys. Not that common in girls, this entity, okay. So some overlapping slides are there. Normal puberty in girls starts with telarchy, then pubarchy, followed by menarche. And remember, adrenarche, which is responsible for onset of pubic hair, is independent of gonadarchy. So adrenarche initiates the onset of pubic hair and gonadarchy is helpful in progression of that hair growth. And next to B1 to B4 stage of breast budding to B4 you require estrogen, but B4 to 5 progression you require progesterone. These are the simple definitions of abnormal puberty. And coming to delayed puberty, absence of signs of sexual maturation by an age more than 2 to 2.5 standard deviation values above the mean of the population, we call it as delayed puberty. So in girls more than 13 years, no development of breast, that is breast stage 2, we call it as delayed puberty. So it's not a rare entity, but this is much more common in boys compared to girls. But timely assessment and management is mandatory to achieve successful long-term outcomes. So when to assess for this delayed puberty? So naturally after 13 years, if still there is no B2 stage of breast or no menarche 5 years after telarchy, that means if there is no progression of puberty, onset is important, at the same time progression of puberty is also very, very important. So if there is no menarche 5 years after telarchy, then also they require evaluation. And most children with a delayed puberty represent physiological variation, that is CDGP, constitutional delay in growth and puberty, which is a physiological condition. But to label it as physiological entity, you must have sound knowledge of this CDGP and other pathologies. So by and large, we divide this into two categories: hypogonadotropic hypogonadism and hypergonadotropic hypogonadism. These are pathological entities. But CDGP, which is a physiological variant, is common in both boys and girls. So coming to hypo, basically it is due to loss of function at the level of hypothalamo-pituitary, that is the switch for onset of puberty. So this loss of hypothalamo-pituitary function can be reversible. Examples like anorexia, athletes, so that is common, delayed puberty, but it is reversible entity. And structural or irreversible conditions like you have genetic causes, any trauma, radiation, infection, lesion at the level of hypothalamo-pituitary can cause either delay in puberty or precocious puberty. So there are some observational studies, long-term consequences of this delayed puberty in girls. These are the observations, like increased risk for early natural menopause. There are some reports of malabsorption and celiac disease, low IQ, asthma, poor overall health, poor sleep and short stature, and reduced risk for obesity. These are all observational studies. And a recent review on this self-limited delayed puberty by Ju and Chan, they summarize that in some of the patients, adult height may be reduced, and late menarche is associated with the decreased bone density in early adulthood, and there is an increased risk of fracture in future. And late puberty reduces the risk of breast cancer in females and reduces the risk of testicular cancer in males. Coming to the etiology of hypo, so just now I mentioned any injury or infection or inflammation near hypothalamo pituitary can cause this hypo, and there are some genetic conditions like classic example Kallmann can cause hypo. So whenever you evaluate for pubertal disorders, whether it is precocious or delayed puberty, think about the hypothalamo-pituitary gonadal axis. In endocrinology, any disorder generally we think about that particular axis. So problem can be at the level of hypothalamus or pituitary or gonadal level. So any metabolic, catabolic or inflammatory stress can cause rise in either cytokines or cortisol excess state. So that is CRH excess will suppress the axis, that is kisspeptin and GnRH, which is a pulse generator. So it is like a switch. So either switch early on or early off or permanent half. That is the problem. So early on is precocious puberty, late on is delayed puberty, and permanent half is permanent hypo. Okay. So this hypo can be physiological or pathological, congenital, organic, or isolated or combined. Sometimes you will have associated pituitary hormonal deficiencies. In addition to gonadotropins, you may have associated growth hormone deficiency also. And this is the approach. So in endocrinology, first we start with clinical history, then physical examination, then biochemical evaluation, then imaging. That is the order we follow. Okay. So delayed puberty with low gonadotropins, that means we are suspecting hypo. So next step is to see the growth pattern. So if it is consistently short for chronological age but appropriate for bone age, think about constitutional delay in growth and puberty, and normal growth pattern without growth spurt, then think about this isolated gonadotropin deficiency or Kallmann syndrome like picture, and late onset growth failure, especially with concurrent diabetes insipidus. That is suggestive of, in case if they have associated intracranial pressure or any central neurological issues, then go for MRI. If you find the mass lesion, then approach will be different. But in general, delayed puberty with short stature in girls, unless proved otherwise, it is Turner syndrome. And but in that situation, you will have high levels of LH and FSH. But here we are interested in hypo. So that is a different entity. So in history, definitely you will see some red flag features. So that is the reason history taking is very, very important, so that we can avoid unnecessary investigations. Okay. Clinical history and physical examination, you will get some clues, like for example, if central midline defects are there, so a single incisor and this micrognathia, any midline defect, think about that central level problem. Coming to CDGP, so there is basically a diagnosis of exclusion. CDGP, constitutional delay in growth and puberty, is a diagnosis of exclusion. So physiological variant of delayed puberty, and here we have two things. One is transient dysfunction of growth hormone axis and delayed reactivation of hypothalamo-pituitary gonadal axis, that is lazy pituitary syndrome. So not only this delay in puberty, even bone age will be delayed by 2 years, and adrenarche will be delayed, and most important thing is olfaction will be normal in CDGP compared to this Kallmann. And here we have that genetic component, dominant inheritance with incomplete penetration. Variable expression will be there, and majority are lean. Then how to differentiate this hypo versus this constitutional delay in growth and puberty? So not that easy. So you have so many overlapping features. So gonadotropins, according to this Chinese medical journal published in 2015, gonadotropin stimulation test is sufficient to discriminate between HH and CDP in males, but it is not required in females. But see the contrast picture published in JCM. So they have concluded that in girls, overlap of basal values are marked and indicating the need for GnRH stimulation test for differentiating these two entities. So we use this GnRH stimulation most of the times in precocious puberty to prove biochemically. So we have two molecules, decapeptyl comes like 0.1 mg and one more thing is lupride 1 mg, that is 0.5 ml. So 100 microgram per square meter of triptorelin or leuprolide of 20 microgram per kg. You can give subcutaneous, simply you can use 100 IU syringe. So differentiation of these two entities, both will have that hypo picture, IHH versus CDGP is not that easy. So inheritance, CDGP is autosomal dominant with variable penetrance, and IHH, that is isolated hypogonadotropic hypogonadism. We have autosomal dominant conditions, recessive conditions, X-linked sporadic, and there is some genetic overlap between these two. So there is a clinical overlap, genetic overlap, and biochemical overlap. Even after stimulation also, it is not that easy. So ultimately, spontaneous or kickstart onset of puberty by the age of 18 years is the gold standard for differentiating these two entities. So why this problem? Because most of the studies are in boys, not in girls. So as such, delayed puberty is 10 times more common in boys compared to girls. That is the reason most of the literature is with boys. Coming to the management, once it is confirmed, then aim is to gradually induce puberty mimicking physiological development. Okay, so rapid induction is not good. We see common blunders even from senior gynecs of starting directly OC pills. That is not correct. And better to start with estradiol valerate and then micronized progesterone. To start with estradiol valerate of 1/4 of adult dose. Then every 6 months you can increase the dosage. Transdermal estrogen availability is a big issue. In case if it is available, definitely you can go for the transdermal because it is superior to oral estrogen. See the equivalent doses of ethinyl estradiol, starting doses and incremental dose and adult dose comparison. Of course, all these things are available in India. And sometimes, even if you are confident it has a constitutional delay in growth and puberty, that is physiological variant, sometimes to overcome parental anxiety, child anxiety, we may use this low dose estrogen for some period, like for 3 months or 6 months maximum. So in that situation, unlike permanent replacement, minimum dose without incremental in dosage, you can give it for 3 to 6 months and can repeat it again after 3 months if there is no response, with a maximal trial for 1 year, that is 2 attempts. So these are the ideal sites for application of that estraderm patch. So basically non-hairy area, twice in a week you can apply. But problem is in India we have only 50 strength is available, especially in Hyderabad only 50 strength is available. So we want only 1/4 of dose. So in that situation we have to cut it. So that cutting and pasting, leakage issues will be there. That is a problem. But estraderm 50 microgram strength patches are available. So definitely superior to oral, you can try. So when to add progesterone? So confirmed case of hypo started on estrogen, and after 2 years of estrogen therapy, you can start progesterone, or whenever you see breakthrough bleeding or spotting, you can start, or ET, endometrial thickness of more than 5 mm you can, and breast staging of 4 you can start. Okay. So 200 mg daily of micronized progesterone or 10 mg of medroxyprogesterone for 10 days, like 1 to 21 estrogen and 11 to 21 progesterone. And full adult dose of estrogen should be used till the age of 30 years to mimic normal physiological estradiol peak. Between 30 to 50, you can lower the dose to prevent, so basically lower to minimum dose to required to prevent osteoporosis, and after 50, then assess the risk. So that is the up to the age of natural menopause, you can continue. If it is permanent hypo, up to the age of natural menopause, you can continue, and at the age of 50, depending on osteoporotic risk, you can extend it for next 10 years. And this is the most common blunder we see from gynecs, starting of OCP in delayed puberty, straight away giving high dose of estrogen plus progesterone. So do not use this for initiation of puberty, okay? So after full development, then you can go for this cyclical OCP. So other options, theoretical, practically not that easy. You have gonadotropin regimens, GnRH regimens, psychology of child, handling of child psychology is very, very important. And whenever fertility issue comes, so HCG, HMG regimens are useful because it is hypo, not gonadal problem. So these are the 10 important points regarding this delayed puberty, hypo. So delayed puberty is 10 times more common in boys, and whenever you evaluate for pubertal disorders, think about hypothalamo-pituitary gonadal axis, and first step in the evaluation of this pubertal disorder is to look for red flags in clinical history and also physical examination, so that you can avoid unnecessary investigations. CDGP, constitutional delay in growth and puberty, is a physiological variant, is a diagnosis of exclusion. Here puberty is delayed but not stalled, and differentiation of these closed differentials CDGP versus IHH is not that easy. There is a genetic, clinical and biochemical overlap picture. There is no gold standard test for differentiating these two entities, and important thing is bone age. It is a very good reflector of hypothalamo-pituitary axis maturation. So persistently low levels of gonadotropins with bone age of more than 13 years is an otherwise healthy child, is possibility of permanent hypo will be high. And CDGP reassurance is enough, no need of any medication. Otherwise, if parents are anxious, then you can go for diagnostic induction. Then OCP, this is one of the common blunder, not used for puberty induction, remember that. And in case of multiple pituitary hormonal deficiencies, or in case if they have associated growth hormone deficiency, first stabilize that one, after that you can go for induction of puberty. And remember, all these hormonal cutoffs are not magical numbers, okay? Thank you. With this, I will conclude my talk. If you have any queries, I will be happy to answer.
We know that the age of puberty has come down. So like girls are getting their periods around 9-10 years. Suppose a girl at 12 years comes that she has not attained menarche. So how do we take it forward? Just wait for another year, not doing anything, or start some investigations?
I think they will redefine the cutoffs, madam. So as of now, up to 13, we can give assurance.
Just assurance that
Yes.
nothing to be done,
Yes,
and
yes.
we wait and see.
Yes, madam. Sometimes we face that situation from parents. So nowadays every girl is getting her periods around 11 years. So my girl is 12 years, still not yet attained. Like that we see in our routine practice.
Good morning. I just want to know, like this IHH, if they present very late, like 21 years, do we still go about inducing the puberty at that age?
Sorry,
After
madam?
ruling out IHH,
Yes, madam.
Hypogonadotropic Hypogonadism, when the girl presents at the age of 20-21, so do we still go about inducing the puberty at that age?
So
After ruling out everything, like it's like an isolated idiopathic gonadotropin deficiency. we can go about inducing?
That 2 years standard protocol we can cut down to 1 year, madam.
Okay.
That is the practical approach.
So we can give estrogen for 1 year, then add
Yes, yes,
progesterone,
madam. Yes,
looking
madam.
at the progress of the
That is the
development.
practical approach.
Thank you.
But better always start with low dose. Shall we close?
One more question. I think the most difficult aspect of treating this is about the fertility part.
Yes,
Whenever
madam.
they come to you, they just ask, am I going to have children? So how do you go about counseling such girls?
Theoretically, yes, madam. So basically, gonads are intact, function is okay with supplement, so 100% possible. Theoretically, yes. Practically, there are so many issues.
We do encounter these HH cases for fertility, and it is not all that very difficult to treat. It's just that we just have only FSH is not going to work. Letrozole, clomiphene citrate, these are not going to work. The first flag point should be that both FSH and LH are definitely less than 5, and they do very well with HMG. Invariably, if you see, most of them do have a good AMH, and they look like PCO ovaries, but they don't hyperstimulate like how a PCO hyperstimulates. You just have to go on a slow step-up dose itself rather than give a high dose and then land up with complications of OHSS. And I think now even the ISMART, that is the International Consensus of Medically Assisted Reproductive Techniques, they have also included gonadal failure into the part of HH management, where the FSH and LH may be normal, but despite the normal routine stimulation, they don't achieve their full potential in terms of developing eggs. They could be mostly because of polymorphism or some other things which require a higher end workup, but even that is also included in this. Your FSH, LH will be normal, but with the standard doses, they don't respond.
Generally, we endos refer to fertility centers, madam. So no more experiments with that hypo.